care and a lot of taking care of things over time. Anesthetic, pre-anesthetic evaluations are all about what's happening right now. What does this patient look like right now, and how badly do we have to do the surgery that we have to do? So you always have the one of the spectrum, perfectly healthy people who need elective surgery. That's easy, right? Don't do anything, just send them to surgery. You have really sick people that need emergency surgery. That's also easy. They're going to go get emergency surgery because they need it. It's all the middle that gets complicated. And there's a couple things to just generally think about in terms of surgical candidates. Changes in exercise tolerance that are not explained. I think that's always an easy one. You have to wonder about decreasing pulmonary function, changes in valve disorders, has something gotten worse, and all those things. If we have the luxury of having elective surgery, we'd love to have all that checked out before we get there. So, and generally a great way to assess that is, can you exercise? Can you do 4 METs, what they always say, walk for 20 minutes. If you can walk a mile or you can walk 20 minutes, and that's not new for you, this is just sort of where you are, then you probably don't have unstable angina, you probably don't have a severe valvular disorder, you probably don't have an arrhythmia, and you're probably not in heart failure. So those are some main things that you just want to avoid. You're probably not having a respiratory exacerbation of COPD either. So, generally, that's something that we look at the day of surgery a lot. Tell us whether this person's where they normally are. Prior airway issues, personal family histories of malignant hyperthermia or pseudocholinesterase deficiency. These are kind of real specific anesthesia things that we always ask about. But certainly if you're doing a preoperative, it's great to have a heads up on the chart saying, hey, this person has a brother or sister that had MH. Just makes it more certain that we're going to catch that. And also it's helpful if you can cue your patients to tell us that. Hey, you should always tell an anesthesiologist about that, because sometimes patients just, they don't know that that's an important thing. So you've all probably seen this a million times. We're going to go over it now. ASA physical status classifications, because the next slide, we're talking generally about something uses this classification. I didn't want you to have not seen it and then I start talking about it. So we classify the patients 1 through 6. It's become an important part of anesthesia billing. So you'll notice all anesthesiologists do it if you rotate with an anesthesiologist. I'm not sure that it's the best tool for assessing risk, but it is the one that you'll see everywhere, and we use it on a lot of stuff. So ASA ones are perfectly healthy patients. ASA 2s are mild to moderate systemic disease. That's just well controlled, basically. Third, you have some severe disease process that limits activity, but the person is still not incapacitated. 4, severe incapacitating disease that is a constant threat to life. Pretty much all dialysis patients fall into 4. Number 5, moribund patient that's not expected to live without some intervention. They're not going to make it through the next day unless this is fixed. Their sepsis is fixed. Their dead foot's cut off, whatever. ASA 6 is really just patients that we do for organ harvest. So there's that, but we're going to reference this on the next page, so I didn't want to leave it. Now this is where I'm going to try to show, the people here have a handout, and the other folks I'm going to show it on the screen, but I'm going to actually pull it up in Microsoft Word because I couldn't get to copy into this really, really well, and I want you to see it. So these are some indications that we use here at Centra for preoperative testing guidelines. So just going over some general stuff here. And this is what we use. And you say, oh, great, now you're just throwing me all the Centra lists or something. I don't care about Centra. But we've reviewed these really thoroughly. We've based them on evidence, a lot of different papers. I can get you all the research on it if you wanted to. But it really goes through the basic things. And really, I think the main thing you need to know is that ASA 1s and 2s, which I went over that ahead of time, really don't need any testing prior to surgery. You can kind of look, also you want to get that within a month. Usually if you're going to get testing, get it within a month of surgery. And it kind of goes through what types of medications you need or should be on if you're going to need a basic metabolic panel, a CBC with major history, or if you have a history of anemia or cirrhosis. You never need an x-ray, chest x-ray. I say that to you, but you guys are really smart family medicine people. If you think your patient needs a chest x-ray for some other reason, and they're coming in sick and wheezing, don't hold off on my account. Of course, we're not looking for someone with pneumonia to come in, and that's not a good time to do surgery either. So I say that we would not get a chest x-ray for an anesthetic reason. Of course, you guys know all the reasons to get a chest x-ray. And if you think they need one, of course, do it. We're going to go over EKG a little bit more when we get to the cardiac section. Diabetics, it's nice to get, we'll get a day of surgery sugar. I think hemoglobin A1Cs are really great. Tells surgeons a lot about wound healing, how well they're going to be able to control their sugars after surgery. And it tells me a lot about how much variability I can expect in the blood glucose. When I have a patient asleep, if they become hypoglycemic, it's really dangerous. You know, no one can tell you they're hyperglycemic once they're under anesthesia. And it's a lot of the effects of that are masked by anesthesia. So that's something we do. Pregnancy testing, you know, we do them on all females that are fertile. There is some thought that that's somewhat paternalistic and that we should change that practice. If you look at the ASA guidelines, they won't quite go there yet, but they're starting to say, should we just explain the risks to patients and let them decide if they want to do that testing? So there's that. You only need PT, PTD, INR coagulation studies on patients that are on anticoagulants, have bleeding history, or have cirrhosis. Okay. And neck flexion is for rheumatoid arthritis patients. If they're on methotrexate, then they if they haven't had in the past years, that's what it is. So that doesn't come up super often. But those are the things that we think about testing guys. Kind of go some boring general stuff. Sorry about that. Then we're going to move a little bit into cardiac. So I couldn't quite fit those testing things into cardiac, pulmonary, or airway. So I just put them in at the front, got them out of the way. Operative risk, cardiac risk. So first thing, you take a good history, you do your good physical exam, which you guys do all the time. Assess exercise tolerance. Oh, that's the same. We touched on ASA physical classification and how that maybe isn't the greatest way of assessing risk. And the good news is there's a lot of really great risk calculators out there. And my favorite one does overall surgical risk, and it goes through a lot of categories. It's called NSQIP. Not sure what an NSQIP, I guess you'd call it. I don't know. And it is online, and you can go there, and it's really fun to do. So we'll go ahead and do it. You can go there and put in your stuff for your patient. You have to prove that you're not a robot first. So make sure you do that. I'm not. Apparently it's convinced. And you put in some really basic information, and it tells you your patient's surgical risk specifically for them based to what the average risk is. So you can do something like, well, let's say I was doing it for me. Okay, so here's me. You can write in cholecystectomy at the top. Okay, and it will actually bring it up. The surgery. Mastectomy, laparoscopic. So let's say I'm going to get that. Say my gallbladder needs to go out, and I'm 63 inches tall. I weigh 162 pounds, and I really don't have any kind of other medical problems. Let's see what my risk is going to be. And it goes to really a lot of really nice serious complication, any complication, pneumonias, return to OR, readmission, death. And you can see all these things are quite low. And you can see that my ranges of these little green bars fall below that. So that black bar is what the average risk is, which is like one, and then over here it says the numbers like 2%, and then my risk is 1.1%. And so it kind of goes through that. And then you can go back and change. Now let's say we're doing somebody who's 85 years old, who's partially dependent, who's diabetic, on oral medications. Sounds a little bit more like your patients, probably has hypertension. Sounds more like my patients anyway. I don't, maybe not yours. Severe COPD. Okay, and now I push continue. And they have a couple extra questions for the sicker people. Let's just say none of those are there. And then you start to get an idea of, well, gee, this patient has a higher risk and a lot, she might need nursing or rehab facility afterwards. She's more likely to need that than the average person. And, you're not getting up into like 50% risk. We're talking 2%, 3%, but it's higher than what would be expected. And that's nice for two reasons. It prepares you for problems that you might encounter with your own patient afterwards. It can prepare the patient for what maybe, because people might ask you, how risky is this? How concerned should I be? This is I think it's a nice tool for that. And also sometimes you have to make decisions about, well, who should I go the extra mile on and have them see their cardiologist, and who shouldn't I? Who should go over and see an anesthesiology consult over at the new pre-admission testing center, and who shouldn't? And maybe when you do these risks, it might make it easier for you to make those decisions. I think it's also fun plugging in stuff. You can plug yourself into it, which is really fun. So I think that's an important thing. That's overall surgical risk. The MD calc is also for just cardiac risk. But I think that's important in sort of stratifying people. And I think we do that all the time as family medicine residents. We know who's most at risk for what. So that's one thing, because I think we all recognize you're not going to have a perfectly healthy patient all the time. You just kind of want to know, what are the risks and what can I manage for those risks? Cardiac testing. The next question is, what should I do about cardiac testing? Should I get a bunch of cardiac testing before an elective surgery or not? Right? I imagine this comes up a fair amount. The first question is, if there's tests that are out there that you've ordered, or cardiologists have ordered, or pulmonologists have ordered, that were going to be happening anyway. Hey, I've been having this chest pain and I have a consult with cardiology next week. Don't come for your colonoscopy the week before. Just get the cardiac stuff done first and then come for that. So I have an interesting personal story. I had a patient that I was seeing in an outpatient GI center, and of course everything there is about moving things along. You've got these are healthy people, supposedly healthy people, that you're going to give a little propofol to. They're going to get their screening colonoscopy, and they're going to walk out of their bed, and they started. And right before about to get started, he said, well, I am having chest pain. I can no longer do, I fixed my fences on my farm. I can no longer do it. And when I'm scheduled next week to have a cardiac cath, I said, no, I don't think you told anyone this, so it's no one's fault. Until right before I said, well, we're going to have to cancel your colonoscopy today. I'm really sorry. This is elective. You have to have that done before you do this. The order's out of whack. I'm really sorry. And of course, he's totally pissed. Totally pissed. He had it all. I have work off today. I've already prepped my bowels. I'm here for my colonoscopy. I said, I'm really sorry. You should have told. We didn't know about this until right now, but this is how it is. And there's not a lot of cardiac reasons to cancel elective surgery. This is one of them. He did end up going and getting his cardiac testing, and he needed 2 stents. He came back, 6 weeks later, and was like, yeah, I guess you were right. I really did need to get that done. This is more important than I thought. So if there's anything that's supposed to be happening and it's an elective thing, go ahead and do it. Encourage your patient to get that stuff done before they come for their elective stuff. And a great way to know that is the AHA/ACC preoperative cardiac testing guidelines, which I have attempted to put on a slide here, and it looks terrible. I'm so sorry. It's like really awful look, but it's actually really easy. It basically, if you work, the steps are on the side here. If you work through those steps, it basically stratifies your patients into groups based on their surgical risk and their medical risk, and then tells you what type of tests they need. And I think that can be really helpful, if any, before a surgery. And spoiler alert, most of the time you don't need any. That's really sort of the usual takeaway on that. But that is cardiac testing guidelines. Then the next question I think that we often get is to get an EKG or not to get an EKG. This is always something people want to know about. And again, we put together a really nice EKG algorithm for our preoperative testing clinic. We're actually opening a perioperative surgical home this January, and we're going to have 4 or 5 nurse practitioners there, supervising anesthesiologist, to try to really get our patients ready for surgery, decrease cancellations, increase safety. And so we've developed some of these recently, and we're still reviewing them, so they're maybe not completely done, but we've been looking at different things. And you can see here, it's really easy flow. Is it a low risk surgery? Yes or no? And at the bottom, I think we list the surgeries, low risk surgery examples, intermediate risk and high risk. You see at the bottom. And I gave these as handouts to the folks that are here. And then their ASA classification and when to get an EKG. And so I think that you could easily just apply this right to your practice as a family medicine. And sometimes a lot of these preoperative things are kind of like this. It seems like, boy, are you dumbing this down for me or something? And I'm really not trying to, but it usually works out pretty well just to follow a pretty set algorithm, and you catch most everybody. And I would think if my patient was seeing a family medicine doctor, I mean, that's great. You should know exactly what to do with this. Even when you look at insurance claims data and things that I've looked at over different articles, family medicine doctors do a great job of saying who's sick and who's not. So I think even beyond the algorithm, it would be just an extra layer of safety having them see you. But that's always a question. They need an EKG, and everyone does not need an EKG, and it's extra money and extra time for the patients and your staff. It'd be nice to have times you say, we don't need an EKG. Let's just skip that. So there's that. Respiratory function. Respiratory function is simple and complicated all at the same time. So it's simple in the sense that overarchingly, you just want it to be optimized. You want the patient to be the best that they are. Not everybody can breathe well without, not everybody can oxygenate well. People live on HOMO2, 4 liters, and we have to do surgery on them. It happens. But you want to know about optimization. I think the tricky thing about respiratory function is that it can change. They can see you or me or anybody 2 weeks before their surgery, and they're as good as they get. Things seem ready, and then a week later they decide to stop taking their Advair or their Symbicort or whatever. They run out of their Singulair, and they show up the day of surgery wheezing, or they get an infection or an exacerbation, and you're just right back where you started. And so I think when I had the opportunity to set up basically a preoperative testing for outpatient surgery before. What I always had the nurse tell my patients with COPD, emphysema, asthma was, if you're doing well, stay on your medicines and just come to your surgery. You can take your inhalers and your medicines the day of surgery. That's not eating anything. That's inhaling something. Great. But if something changes, you have to call me. And then we can treat it if we need to. If you need to have antibiotics or steroids, we can probably keep your surgery on track if we can get that done. But if you're not better by the time you get to surgery, we have to cancel it. And that usually motivates people to communicate. And usually if they can communicate, even a week to 3 weeks beforehand, it works out great. A little bit different for kids. Kids tend to have a tendency to wheeze after an asthma exacerbation for up to 3 or 4 weeks. So if you called me a week before and said, hey, I've got this 6-year-old who's asthmatic, who's wheezing, I'm going to get her on some steroids and I'm going to have her do her albuterol nebs. Is she okay for next week? The answer would probably be no. We're going to go ahead and postpone your surgery for 4 weeks or until she's well, and at plus 4 weeks. So that's the only caveat to that. But most adults, if you can catch it, a week, 2, 3 weeks out, start them on some antibiotics, get them back on their, fix whatever the problem is, they're usually good. But the tricky part is the communication. PFTs are usually not necessary for surgery. There's only video-assisted thoracic surgeries, or the surgeries where we're going to actually deflate a lung and do surgery on it. You usually don't need a PFT for any other reason. Obviously, if you think medically it's going to guide your therapy in some way, get a PFT. It doesn't hurt. It's nice to have, but usually clinically we know if someone has, restrictive disease or not, whatever. So that's great. Going to move into the airway a little bit. I have some slides. We're going to run through them real quick. Anatomy of the airway. We have the oropharynx, the nasopharynx, the hypopharynx is back here, epiglottis here, the larynx, esophagus is behind, cricoid cartilage is the smallest part of the whole trachea, soft palate, hard palate, and cricoid cartilage. So this is an LMA that's in there. So this blue thing sits right above the glottic opening, the opening to the lungs, and allows us to breathe for people. It also allows them to breathe through it real easily. So we'll think about that. And it comes up in a little bit of a while when you look at this picture. If you don't like this picture, it looks really busy, but I really like it because it talks about what you're doing when you're trying to intubating people and when you're trying to ventilate people and what gets in the way. So this picture over here, sort of the upper right one, talks about proper alignment for intubating someone. You're basically trying to get a visual between the plane of the oral axis, the laryngeal axis. You're trying to make those two meet and line up and visualize them, and then stick a tube into it. And if you look at the pictures for a little bit, kind of when we get to the different problems you can have with airway, you can start to see why that might be harder in certain types of people. Well, if the chin's shorter, what will that look like? What if the tongue's bigger? What if your head is in some weird position? If you're intubating people on the floor, this happens a lot. They're never in a good position. It's those beds that are too low or whatever. So it can help you a lot too with your intubating technique when you're thinking about where am I relative to these axes with my line of sight. So that's from another lecture. that I go into a lot more detail on that one. But I thought it'd be important to put that out there, because then when you start talking about the problems with airways, it's a lot easier to see some of them when you think about the anatomy. So these are some, just sort of a laundry list of reasons why people have a difficult airway for mask ventilation. So the top one is talking about difficult mask ventilation. So there's a lot of ways we manage the airway, one of which is we mask ventilate. And I'm not going to go through that because I think you guys know different about that. Previous head or neck surgery, lack of teeth, they have a beard, and they're being a high BMI, or having sleep apnea or snoring history. Okay. This is potential reasons why people have difficult direct laryngoscopy. So history of difficult intubation, if you hear about someone aspirating after intubation, or trauma to the airway during an intubation, those can all be signs they've had a hard time being intubated. OSA, previous head or neck surgery, radiation or trauma, congenital diseases. This one is kind of tricky. There's a lot of them. I have a slide with all of them on there, or at least the main ones on there. And that, is something that obviously family medicine doctor would know about those diseases, but it'd be nice for them to know that those are actually risks for intubating people. So Down syndrome patients, I have a quick case we'll do with them. We'll talk a little bit why their airways are different and why they are more likely to have problems with obstruction and intubation. Rheumatoid arthritis can cause a lot of stiffness in the neck, which can decrease neck flexion and make it difficult to intubate them. Scleroderma patients can have some challenges there too. Obesity, any kind of C-spine or previous surgery, cervical spine stuff. Hey, question, go ahead. Yeah. Well, let's go back to it. Lack of teeth for mask ventilation is more difficult. Intubating, it's actually easier. It's a bonus. Right. Yes, you're picking up. Good job. So, but for mask ventilation, the cheeks and everything just kind of drop in. The teeth kind of hold out a lot of that. And so it's easier to just have a passageway for you to ventilate through. It's a great question. You picked right up on that. Good job. Very good. All right. So there are a lot of conditions that affect the airway, and congenital ones. There's Downs, Goldahar, Kipple-Feel. I intubated a Kipple-Feel one time. Gosh, the person looked like SpongeBob SquarePants or something. No neck at all. There's the head right on top. It was terrible. Pierre-Robin, Treacher-Collins, Turner syndrome. And there's a lot of pathologic states that we see. Epiglottitis, Ludwig's angina, croup, tetanus, foreign bodies, basal skull fractures, scleroderma, hypothyroidism. All these things can contribute to problems with the airway. And we're going to look at some cases on some of those that are really interesting, I think. Components of an airway physical exam. We always talk about Mallampati scores, and we'll definitely talk about that. That's how visible the uvula is when they open the mouth. But you have to think about when you think about that idea of aligning the oral axis with the laryngeal axis. The oral axis is, pretty much when you're in neutral, it's kind of parallel to the floor, and the laryngeal axis is kind of almost perpendicular to the floor, a little less acute, less than that. But so it's difficult to do that when you have upper incisors. It gets in the way of aligning those two. The prominent upper incisors will block your line of sight. Overbite, underbite, being able to voluntarily protrude your mandible. If someone can't do this, they don't have the flexibility to push their mandible forward, they probably could be difficult to intubate again, because you're kind of get this whole mandible out of the way to be able to see where you're going. Thyromental distance refers to how long or short someone's chin is. Usually you can put 3 fingers kind of right here between the mentum and the thyroid cartilage. And if you can't, it's potentially more difficult. Length of the neck, having a longer neck makes it easier. Short necks are harder. Thickness of the neck, bigger necks are harder. Range of motion. If they can't do this, you're really going to have a hard time aligning those axes. And so most of the time, the basic teaching on this is it's not one thing that will usually make it super difficult. It's if you start hitting 2 or 3 of these things on this list, then you'll start seeing difficult airways. In fact, I worked with a guy who used to make, those plaster masks of people's faces. You can kind of make those. I think they used to make them like a long time ago for people, like a bust of them. He used to make those for patients that were difficult airways, and he had a bunch of them lined up. And I think his research revolved around Is there something about looking at someone's face that tells you that's a difficult airway after a while? And what is it about their face that's similar? So he would, but it was kind of creepy. He had a bunch of those up sitting around, sort of scary. Anyway, thyroid mental distance, short, thick neck, and neck range motion. I think that was already on the first slide. I don't know why. Just giving you an extra slide there. That one's for free. Malin potty score. Here's a picture. One, as you can see, the whole uvula. 2, you can only see the soft palate. 3, you can see 2, you can see part of the uvula. 3, you can only see the soft palate, and 4, you can only see the hard palate. Okay. And that's something that you ask people to do. I also noticed intersizer gap less than 3. So that's if you go like this. If you don't have a gap of 3 centimeters, you push that forward. Then we'll do some cases. So the first one's really easy. We do this all the time. Someone who's 25 years old, and this is going to involve mostly on airway. I think the cardiac and the pulmonary stuff we talked about at the beginning, there obviously are cardiac problems that Down syndrome people can have. We're kind of not going to go there. We're just going to talk a little bit about the airway. I think a lot of those cardiac and pulmonary things, if you have a basic algorithm to use and you know as much as you guys know about pulmonary and cardiac function, you're going to do great. Well, I don't know how to get that bigger without doing that. Okay, so 25-year-old patient presents for dental cleaning and extractions under general anesthesia. So, you know, a lot of folks with MR Downs won't or can't get their teeth cleaned. So we put them to sleep under general anesthesia with the breathing tube so that the dentist can extract teeth and clean teeth. And it can be really, really impressive plaque going on in there if you've ever watched that. Wow. He is obese. He has Down syndrome. He's on any meds. He has no allergies. Mom says his heart's fine. His thyroid's okay. He doesn't have, you know, but so now we're going to start thinking about some issues that you might have with this patient in terms of airway. Anybody have any ideas? Here's a picture of him. That might help. Do you think he's going to obstruct when you put him off to sleep? Yeah. He's going to be really difficult to mask ventilate. You can see the large tongue really nice in here, and a small mouth. They tend to have a small mouth. And so he's going to be difficult to intubate. He's going to be difficult to ventilate with a mask. So sort of what should be like kind of a simple case kind of becomes more complicated and more risky. And I think you'd have to really pause if this was your patient and they were going to telling you, hey, I'm going to go to this place and get some Versed and fentanyl for this. You know, I think you'd have to say to them, that's probably not a good idea. And this is why. If a dentist or a dermatologist, it just isn't looking at that, you've got to think about that. And here's a slide that talks a little bit about it. They can also have C1, C2 instability. So that's kind of one we don't always think about, but they can have atlanto-occipital instability, and so you can, I think you evaluate that by having them go like this and asking about numbness and things. You can also get some imaging. I have to admit, I really rely on people like you to get that stuff done before I come. I'm not sure that I would. You know, I like it when someone has it all finished for me. That's great. Protruding tongue, hypoplastic. They also have a real short mandible. So again, if the mandible is shorter, getting that view is really, really difficult. And all that extra tongue tissue is going to make it really impossible to ventilate this patient. So they would be high risk for airway problems. You also, other things with Down syndrome, they can have what's called subglottic stenosis. So they can have actually the smallest part of their airway is below the vocal cords. So you can actually get a view, start passing a tube and not be able to get it into the trachea. And you have to downsize to a smaller tube. Again, just a little fun little fact on that. So there's them. I think I'm doing okay on time. Yeah. Case 2. We've got a 76-year-old woman who prevents for total knee replacement with reflux, hypertension, and scleroderma. She has no allergies. Before you get anything, we're going to say, oh, can you open your mouth for me? That's, you notice all anesthesiologists start with that. It's really fun. I love when people are embarrassed about their mouth. Oh, I don't know my breath. My teeth. Oh, don't worry. I've looked in lots of mouths. Not going to scare me. I open it up, and this is what she does. And so there's some interesting things about scleroderma and the airway. They cannot, sometimes that skin becomes so taut they can't open their mouth. And in fact, you can sometimes accidentally almost rip the skin at the edges of their mouth if you try to open it real forcefully. Again, that might be a challenge. And that one's a little bit more subtle. And someone like you that knows your patients might know that. You know, this patient might have complaining about not being able to eat well or open their mouth well, and others for other reasons. And that might be something you would think, hey, maybe she does need an anesthesia consult. This could be more difficult than people would anticipate. Tight skin. They can also have TMJ, make it difficult for them to open, and they cause it real tight skin. They can other conditions can cause this too, burns to the face, radiation, but that's always a little more obvious, I think, than scleroderma. I've been surprised with a couple scleroderma patients. I see scleroderma on their history. I think, okay, whatever, don't really care. And then they come in and it's like, oh, wow, this is really going to be really a problem. So final case, we're just gonna do one more. I don't know how many, I guess your family medicine. So you guys you potentially can take care of kids. So this is great. And the 6-year-old presents the emergency room with high fever, sore throat, difficulty swallowing, no passability, no allergies. You go in to see the patient, and here's your look. He's it's like, there's you guys call tripoding when they lean forward like that. He's doing all that, really drooling, difficulty breathing. He's tachycardic. You open his mouth. That's what's inside. And I bet you guys are going to get this right away. I gave this case to my medical students up at LUCOM. They didn't get it, actually. One of them got it, some of them didn't. So what sign is that? The thumb sign. What does this person probably have? That's right. Yeah, so if you saw this patient, that's a surgical emergency. You don't want to give them any kind of sedatives or anything like that. They will, that epiglottis will, if those muscles relax at all, and that's why this child is not relaxing, that epiglottis will just act as a valve and cover right up over the larynx. You won't be able to intubate them, and they will not be able to breathe. So that's kind of a challenging airway case. Here's a picture of the epiglottis being swollen. This is it up here. It's normally just a small little thin thing. I guess I should put that picture in here. I had it in my other airway exam that I gave, but I took it out earlier. But this is a very large epiglottis. It should just be a small, thin, almost pointed structure, and it's just this large globular thing. And that's the trachea down, that little black thing down there. You could probably intubate this patient, but it wouldn't be easy. That's the retinoid cartilage, backside of the posterior edge of the glottic opening. Shouldn't be attempt DL. You normally do an inhaled induction while maintaining spontaneous ventilation. You don't let them stop breathing on their own. Use a smaller tracheal tube. And only induce in the OR when you have all the equipment in person, and also have rigid bronchoscopy on ear, nose, and throat available to put a trach in if you can't intubate them. So that's kind of a fun little case. So I've kind of gone through some of the things that I thought about with cardiac and respiratory and airway issues in preoperative management. I'm wondering if you guys have cases or questions for me. I hope we could guide some of that way, and I could improve this because, oh yeah, go ahead. Great, hi. And that's just it. That's partly what makes it trickier too. It's just not as quite, the AHA and the ACC have gone through a lot of trouble to stratify that. I think you could probably look at that surgical risk calculator and look at some of the factor risks for things like pneumonia, reintubation. I think those are on there, and that would tell you about that. People with lung problems, but really the main thing is you can do surgery on almost anyone if you have to, and if it's elective, you just want to know how bad it is and get it as good as you can get it. Worst case scenario, some things you just do with the block with the patient awake. If it really needs to be done, the patient really wants it done, they're motivated that way. But there isn't as great, not that I haven't found a really great way of stratifying that. And cardiac is definitely more clear because of the work that's been done in that area. And I think the expense of all the testing has kind of pushed it that way. They're not going to get a stress test on everybody. Well, they were doing that for a while. They're doing all kinds of work up on that. But it's a great question. There really isn't anything out there that I know of. If you guys know of something, tell me. I'll put it right on the slide and we'll talk about it. But I don't think there is. And that's part of the challenge with it. It's all about optimizing, and that oftentimes relies on the patient being reliable and willing to communicate that and get treatment. Great question. Go ahead. Well, that's really interesting. The first question was, well, I want to try it. That's my thought. I want to go ahead and do it. No, what you would probably do is you would probably do what's called an awake intubation on that person. And if they're motivated enough to do an awake intubation, then they're probably okay to get to surgery. I think that's usually if you tell them that's what you're going to do and you meet with them ahead of time, say, hey, I think this is bad enough what you've got going on that we're going to just do that, put the breathing tube in awake as soon as it's done, put you to sleep. That will probably tell you how motivated a person is to get an elective surgery. And if they really feel motivated enough to do that, then we can do it. Yeah, great question. Good one. Anybody on Teams with questions? I don't know quite how to get your questions, but see if I can. So I'll stop sharing and that'll open it up. And I cannot access the chat, but oh, okay. I can't, when I click on the cloud, it says it's only for team members only. So I can't see the chat. Could someone read me the questions from the chat? There's nothing there. Okay, I thought you were saying there was. Okay, great. Anything else here? Oh, sorry. Hi. Yeah, take your time. Oh, yeah. Right. Right. So there's really not anything from a cardiac standpoint that's going to cancel your cardiac surgery except for 4 things. If you're going for cataract, which is completely elective and low risk. And again, that takes you right back to those ACC guidelines. I passed out a sheet on it, slide. Decompensated heart failure, new valvular disorder, severe arrhythmia, and missing one. Oh, unstable angina. So if they're not having any of those 4 things, they're good to go. Yes, even with low, yeah. So it's really difficult to cancel those. So if that's I think the only caveat is if the patient for some reason is having that cataract surgery under general, i.e., they went to do it under local at the office and freaked out, which happens sometimes. Then they have to come to the hospital, have it under general. Then that might change your risk classification. But by and large, there's not a lot of good reasons to cancel somebody for a low risk. And you and I both know those cataract patients are super sick. I mean, they're always super sick. Next question. No, it's not at all. Thank you. Okay. Oh. Right. Oh, I appreciate that. Thank you. That's exactly right. So all I need you to do is you can risk stratify them, determine if they need any testing, and say, do they need like any kind of preoperative evaluation? Usually that's airway. People want someone to look at the airway. You guys usually can figure out what testing they need, and then I take it from there. That's really what we need to know. I think it also helps the patients to know what the risk is, because that's what patients are. Well, how risky is this? Well, it's always relative to how risky it is to everybody else, depending on their thing. So yeah, great question. And we were talking earlier about a really nice calculator to use for that. Let me see if I can get back to that. I'm not sharing my screen anymore though, so let me see. We went here. It's the NSKIP calculator, and it's a great way to calculate surgical risk for a lot of things, and it can be helpful for your patients and helpful, I think, in your decision making on saying, hey, this is a high risk person. I really want to make sure they're supposed to go get this heart test. They skipped it. Let's get that done. This person's higher risk versus, they probably don't need to do that. Great question. Yeah. So what it does here is you put in all this stuff about yourself, your patient, and then you go here, and it basically this whole this column says your risk versus average risk. and it breaks it out by different types of risks. So, your risk of being discharged to a nursing home afterwards, your risk of having any complication, your risk of serious complication, how long will you likely stay in the hospital after the surgery? And that's something every old person I know wants, how long do I have to be in the hospital for? Well, maybe you could give them, probably there's some surgeon preference there, but also you could say, well, this is what the average risk for you of staying in the hospital would be for you, predicted risk. And I think that's a nice tool too. And it also kind of breaks it out by cardiac complication, surgical site infection. I think that's just and we put in a fake patient there and just kind of ran that. I always go to it on the website. Let me find it. The website is called, where did I put that? Let's see, up here. I think it's here. No, where are you? Where are you? Yeah, NSKIP. I could say NSKIP. It's this bottom one here. NSKIP for surgical risk. It's riskcalculator.facs.org. And I always just use it, but I'm sure they have an app. I mean, who doesn't have an app? We all should get an app probably just for whatever we're doing. Yeah, that's a really good question because I bet you guys get that all the time. Hey, I don't need you to tell me what the anesthetic plan is. I don't need to clear them for surgery. If they need to have the surgery, I know what I'm going to do. I just need you to help get the things done that will make this patient safer if they need to be done, and get them optimized from a cardiac and a pulmonary standpoint prior to coming. Which you guys know. You guys do great at that. That's what you do all the time. So, yeah. Yeah, it looks like this. It looks like this. Let me see if I can go back to the original homepage. It makes you make sure you're not a robot before you get started. Does that say that? This is the opening page to that. I'm not a robot. And then you gotta pick the taxis. And then I have read. And then it will ask you really simple questions about, you put this type of surgery up at the top, and it'll actually, you start typing in, it will fill it in for you. It'll give you a drop down. I think it's really nice. Yeah. I hope not. Oh no. Yeah. Yeah. It would ask you, I think, to pay for it. Hope it doesn't cost a lot. Oh gosh. Now I'm worried. I just charged you something. And these are all simple questions you would definitely know about your own patients. So I think that's a really fun one too. What else are we thinking? I said some good questions. Oh, right. Like the meeting link. I always go on the website, but that might be old school. I mean, maybe it's time for me to move on. Surgical risk calculator, ACS NSKIP. Thank you. I appreciate that. Was very thoughtful. Thanks, guys. Thanks to all of you.
Still working.
Is that
Yeah.
a phone?
Yeah.
Oh, okay.
See, it says recording has started.
Right.
It is still recording, 3 hours long because somebody is still in the meeting.
So I guess when
Can you edit that?
Then I can
Alright.
try stop recording.
Oh, boy.